I now have the opportunity to introduce Dr. Gore. Dr. Gore is well known at Downstate. He is clinical assistant professor and attending emergency physician at Downstate and Kings County in the Department of Emergency Medicine. He is the founder and executive director of the Kings Against Violence Initiative, or CAVI, a hospital, school, and community based youth violence intervention, prevention, and empowerment program for teens and young adults. Welcome, Dr. Gore.
Thank you for having me today. Dr. Elke mentioned something that, I try to get across to most people I speak with, and I want to reiterate it again. It's coming up with creative solutions. We know that our country is not at its best, and we're not functioning in its most optimal state. We understand the disparities that exist for everyone here who works in Central Brooklyn and who live in Central Brooklyn and whose family members are members of the Central Brooklyn community. Whether it's violence, whether it's hypertension, whether it's heart disease or new HIV cases, it tends to look like it's the same sets of people suffering from the same sets of illnesses in a very similar way with worse outcomes. And so I bring this stuff up. I don't want to really talk too much about violence and conflict because we're speaking to people who already understand the scope of the problem. What I'm going to be talking about over the next few minutes is really about mobilization. In academic circles, we tend to fixate and pontificate on a particular problem and solution, and we do the research on it, which is needed, but there tends to be a disconnect with mobilizing the ideas and the thoughts around what we've been studying to actionable items. And, a little bit about, what we do with CAVI. So CAVI is a violence intervention program. It's a hospital, it's school, it's community based, and really grew out of some of the work I've been doing with our Department of Emergency Medicine in the global health space and stuff I've been seeing within residency, looking to ensure that people we were caring for within our respective communities didn't have to be patients. And it's a weird concept to go into medicine and say, I don't want to take care of patients. I want to make sure we create modalities to prevent people from having to come into the doors of these institutions other than saying hi and coming in for a maintenance checkup. But I got a lot of pushback from it because it said, oh, what you're doing is not going to make a lot of money, which wasn't my reason to go into healthcare to begin with. And so, when I say I don't want people to become patients, it doesn't mean that we don't have institutions that can care for people within the community. But if we're focusing on accessing people once the problem has already become a chronic, uncontrollable condition, then we've that window of opportunity at providing something life altering has somewhere come to pass. And so when we started creating CAVI, I had been trying to put together a hospital-based intervention program for probably about 6 or 7 years and got a lot of pushback. Part of it is because you're working within a bureaucracy, and bureaucracies exist often to maintain a status quo. But when you're working up close and personal with people who are being affected and infected with different problems, and you see a way out, you can either say, I'm just going to ignore the solution idea that I have, or you can, start looking at creative ways to moving beyond what's in front of you. And the first issue that I came across and recognized was that we were trying to create a program that looked like your average university hospital-based program. You have an idea, you apply for a grant, you wait for that grant to come in place, and then after that, you start to implement a program. Well, what they don't tell you is that anytime you get a grant, whether it's a private grant and definitely a public grant, that money doesn't come right when they say it's supposed to come. You may have 6 months to a year to even 2 years for some of the more the government-based grants. And a lot of times people get so caught up in an idea, they don't actually implement something. So there's a concept that I learned pretty recently, but it was something that we were already doing, and it's something called the MVP, which is, it's not your most valuable player, but it's your minimum viable product. So what is it that you're going to put out? What idea that can be an actionable item that can actually change this problem that you're hoping to tackle? In my case, it's been looking at interpersonal violence and conflict, which is really tied into a number of other series of health disparities and social determinants of health that everyone on this call tends to recognize. The reason why we didn't get funding for CAVI early on is because people don't believe in theoretical programs. You have an idea or concept and you don't have a level of sweat equity, or you haven't really invested a certain thing. Why should your funders want to invest in what you're proposing? And so we wound up launching our program without any money, and I did it out of my own pockets. And want to bring you on a team, but I didn't do it alone by myself. I got to give a shout out to the folks at SUNY Downstate School of Public Health, because those were some of our first interns. They had to do their fieldwork assignment and spent 200 hours throughout the course of the year, or the MPH, helping assist us with programming. The programming that we wanted was to do a hospital-based intervention, working with victims and survivors of violent trauma, making sure that we provided resources. But in order to recruit people to come to a program that didn't exist beforehand, you've got to kind of have some sort of nidus, and people don't want to invest in something that they've never heard of. So we made the decision to start doing programming at the area high school right across the street, which was already chopped up in a series of different schools, which already had issues with interpersonal violence. There was already issues with gang activity, but going to a place that already had a pre-existing infrastructure already gave us the participants that we needed. And we already had a program on paper and said, we're going to test it at your school pro bono. Give us your poorest performing students, your students who are having issues with interpersonal violence, conflict, give them to us, and we will provide this entire curriculum. And the school principal said, here, take them. And, after a couple of weeks of doing that, the students started coming, and we had to chase them around the building to participate. One student said, I don't want to be in that group because that's where all the problem kids go. They already know who the problems are. They already know the issues that exist, and no one wants to be isolated and marginalized. But after a few weeks, they started coming back to us because they realized that we were providing something that the school was lacking. We were providing a level of consistent mentorship, and we were engaging with them in a way that they weren't penalized because we weren't grading them. So it wasn't necessarily the science experiment. It wasn't necessarily, we tracked data and stuff like that, but we wanted to make sure that those students had a regular resource and someone that they could turn to in the event that there was a problem that they were experiencing. So that was the first thing. Each week they kept looking forward to us more and more and more. And without any financial money, we expanded the program to have over 60 students participating in programming 5 days a week. And eventually we're able to recruit volunteers to work at the hospital-based intervention. All you got to do is exist. And then after that, once you take a picture and show something, then other people will decide, I want to invest in something. I may not understand it, but I see some of the elements that they're doing, and I think I can probably give some good advice. And so we started recruiting people, which the second concept was that money isn't your only resource. The first thing is the concept of sweat equity, where people don't want to invest in something that they don't see that you're already vested in. The financial piece comes in, or at least, just the resources, that money isn't the only resource because nobody's going to invest in you unless you already have something that's up and running. It wasn't until we've been doing programming for at least 2 years before we saw our first dime. And it took at least 6 months after the grant was promised and after receiving an actual award letter that we were able to even be able to use that money. I still paid people out of pocket for 6 months. And so a lot of people, when you start looking at implementing programming that communities benefit from, or even just looking at what a startup looks like, you've got to be willing to invest in a lot of resources, which kind of leads me to the next thing. And this is something that a good friend of mine who's a hospital administrator Susan, I'm having a brain fart with what Susan's last name is. She said, one of your problems is you don't have a diversified funding stream. And so for people who are in the public sector, who are in academic institutions, who study material but aren't used to creating actionable items, who aren't used to creating a minimum viable product and investing their own money and resources, they don't understand what a diversified funding stream means. For all of us who are on this call, who've spent money on a grant, you realize it goes like this. You've got your idea, you've got your concept, you decide to implement your project or program, but if that grant doesn't come through and you've already been up and running, how do you maintain that level of consistency? And most of the programs that we're talking about are things that implement people who don't have the same sets of resources that your most viable community has access to. And for you to stop or withhold treatment or an intervention because you don't have money, one, is dangerous for that individual, because it's kind of like you're partially treating them, and you wouldn't give someone a quarter of an antibiotic prescription. You want to give them the full course so that you can wipe out whatever particular bacteria that you're trying to kill, so you don't wind up having some resistant form of bacteria that winds up taking over, which is what we're dealing with MRSA. To withhold the treatment with a community-based intervention can be detrimental, counterproductive, and set you even further back when you have those resources. So if you have a government grant, you kind of have to figure out, well, if my money doesn't come through, who do I go to even give me a loan to maintain the programming? That's one thing. Looking at other forms of diversified funding, I mean, a loan isn't necessarily funding, but it'll keep you afloat. And I've been there plenty of times in order just to make payroll with our staff with getting loans from the Department of Emergency Medicine. Luckily, there's already a nonprofit, and Dr. Lucchese and the team were able to help us make payroll. But diversifying where your funding is coming from, meaning mixing the public and the private, small grants and large grants, so that you always have money to be mobilized for you to continue your operation. In addition to that, identifying members of your team and extended cohort who are willing to be able to do some pro bono work for you. It's not optimal, but again, if people are willing, if they see that you have a level of sweat equity, meaning you've established yourself, you're putting in extensive resources, they see that you are willing to continue with these efforts despite the resources that you're getting, it's easier to galvanize people on your team. And so these are things that we've been doing and still wind up doing with our CAVI team to ensure that programming exists. Now, once you've already been up and running, and so we're in 2020, CAVI existed as a concept. It wasn't even called CAVI, but that was back in 2006 when Ray Austin and I were working on violence intervention efforts. 2009, we had a name and a platform with just, doing more advocacy work as CAVI. 2011, we launched our programming within the school system, and then by January of 2011, 2020, we wind up doing programming in the hospital with a volunteer-based staff, with people that I had recruited from the ER. So a lot of times we tend to focus on academic circles as far as finding our participants to help us with these efforts. But the first, in addition to the Downstate students, School of Public Health students, the other people were my friends from college who know me, understand me, and are willing to put forth some effort for community-based intervention. And so just like you would diversify where your funding is coming from, you also have to diversify where your staffing is coming from. College students and graduate students are great, but they are going to be with you for a finite period of time. And once the degree is over, unless you've really built up and established a relationship with those individuals, they're not going to be able to participate and continue on with programming. MPH students, much better than medical students. Medical students have schedules are too erratic. And, some people go, wow, this is not really the public health talk that I thought you were going to give. But if you don't have access to the resources on an ongoing basis and realizing the different dimensions and the different elements of how these resources get mobilized, you don't have an intervention. You don't have an intervention, you don't improve on these disparities that exist. You don't improve on the disparities that exist, you are back up Schitt's Creek, and we're looking at 1980 all over again as it relates to violence and interpersonal conflict. And these are all people that are being impacted and affected by it. This is not something, it's not just an academic exercise. And so as we move, I have to again shout out Dr. Elke, making sure that we come up with creative solutions. Creative solutions mean interventions, but creative solutions are also in the fundraising and how do you finance these operations? Our goal is to move from this nebulous concept, this nebulous idea into something that is actionable and something that's tangible and something that also has the capacity to grow. One of the problems that I've seen, I've been at Downstate in county for 14 years. Some of the, Dr. Sally Fu remembers when I didn't have gray hair in my beard and I had a full head of hair that went down my back. Dr. Elke as well, probably remembers me from back then. But some of the things that I clearly see within academic spaces that we are afraid to fail. In the nonprofit realm, in the for-profit realm, in the startup realm, you realize that if you look at anyone on this call is familiar with engineering, design, process thinking, you are looking at what is this problem I'm trying to solve? What are the potential ideas and things that I can brainstorm to figure out this problem? What are some rapid prototypes some ideas that we can have? Then how do we create a rapid prototype, which would be very similar to your mean viable product that we can implement in order to tackle this issue? But then because you're looking at the cyclical nature of this design process thinking, you go in after you've figured out and tested this prototype, you go, how do we improve on what we've created? What medical students and what people within our space oftentimes do is that we try to perfect this product before it gets implemented, because we're looking at models from how do I get a good grade, not how do I actually get something that is tangible and something that we can work with. You want to fail as quickly as possible so that you can kind of move on to the next idea and not be so caught up and emotionally attached to a particular outcome. Kavi itself started to make major headway with our programming after I scrapped the idea. I should say after our team made the executive decision to scrap the idea of a hospital-based intervention at first. There's so much politics with doing things at Kings County because you're dealing with the city, and we were asking permission. When we decided to take it outside of the institution and start building with the community in a way that we could hear what the community's needs were and then keep tweaking it every week over and over again, we had a mean viable product. We had an actionable item, and we had something that we've been growing and perfecting and kind of going back to the drawing board because times change, resources change, students change, administration has changed. And so you constantly have to keep retweaking that. But if you think about this concept of implementation and engagement as a way to, it's this continuous cycle, you don't feel like, I'm not really failing at anything. I'm just making these constant, never-ending improvements. In Japanese, in the martial arts and business, they talk about a concept known as Kaizen, which is constant, never-ending improvement. And so if we're looking at these ideas to action as forms of constant, never-ending improvement, then we have something that the community continues to benefit from and our society benefits. I'm not doing this work in order to, it's not just violence intervention. We're looking at this end goal as, how do we create a society based on wellness? And if we're looking at just that end product alone without understanding the processes that are required to make an effective intervention, if we're just checking off those boxes and not really looking at what am I learning here, what can I retweak, and how do I perfect this process, then we are going to continue to miss out on a lot of quality interventions that could be life-saving, life-altering, and transformative.
Thank you so much, Dr. Gore.
Thank you. I don't know if was that too much or was that helpful? I always wonder.
That was great, actually.
Okay. Do we have time for questions? I don't know. I'm not sure if there are questions either.
Not Currently, we're on a very limited time-based schedule. But
Okay.
if anyone has questions, of course they can email us, and we'll get those questions answered.
Okay. Awesome. Thank you, guys. I
Thank you.
appreciate you. Got to catch up with you all soon.
Okay.
Thanks.
Thank you so much, Dr. Gore, for highlighting the way we can use diversification within our interventions, within our connections, and within our portfolios as an academic institution. And it highlighted many different points that we can look at.